Good morning, everyone. If you're just joining us, or welcome back if you're back to the session here. My name is Mukesh. I'm the Chief Financial and Operating Officer at Michael Smith Health Research BC, and I'm pleased to be with you here today. Welcome to the breakout sessions on, we have two presentations today, 30 minutes each. The first one is on Health Data Research Network Canada by Dr. Kim McGrail and Claire Bertran, followed by a session on Better for Everyone, Why EDI Makes Better AI by Dr. Lovedeep Gondara. So each session will have 15 minutes for presentation, followed by 15 minutes for Q&A, and we will follow the first session with the second session right away. If you need any water, there's some water in the back, and restrooms are here. So without any ado, we'll start with our first session, Health Data Research Network Canada. So Dr. Kim McGrail, a leading expert in population health research and data governance, playing a key role in advancing the use of linked administrative health data to address complex health system questions in British Columbia and across Canada. And Dr. McGrail is a scientific director of the Health Data Research Network Canada. And Claire Bertran has dedicated her career to advancing health equity through collaborative strategies that foster thriving communities, integrating the perspectives of diverse, marginalized voices. Past experiences have led her to advocate for public participation in decision-making and to promote the integration of lived experience in research. And since moving to Canada from France in 2006, she has been active in the Francophone science policy community through her volunteer work with the Canada Science Policy Centre. So please welcome Dr. McGrail and Claire Bertran.
Thanks so much for the kind introduction, and thanks for everybody for being here. I'm going to give you a little bit of a background in Health Data Research Network Canada, and then I'm going to pass things over to Claire to really focus on the public involvement aspect of our work. So just to give you a sense of what we are a SPOR-funded entity, so we are part of that strategy for patient-oriented research. We were funded as the Canadian data platform, so trying to encourage and support the ability for researchers to use data from across the country to do research, whether that is pan-Canadian research or comparative research across provinces and territories. It's all of the kinds of things that we can't do with the data that are available through the Canadian Institute for Health Information or Statistics Canada. They have lots of data sets that are available, and many of them are linked, but it leaves a lot of things on the table because there's a whole bunch of other data sets that are really valuable, and including researcher-collected data. So we are working with all of these groups to try to fill in the gaps and make more things possible. So the vision that we have, which is much, much bigger than HDR in Canada alone, is that data across Canada are going to be used to make improvements in health and health equity. And then our particular mission within this is bringing organizations and people together to advance all of this. So this is about collaborative work, and we really do take the network part of our name very seriously. And then you can see the values that we bring to this. And this is a bit of a sense of who our members are. We have provincial data centers in all 10 provinces now. We actually helped to open new data centers in Saskatchewan and Prince Edward Island. We're working with the Yukon to help build their data system and how they want to organize things, as well as Northwest Territories, and we're still working on developing relationships with Nunavut. There's just been a challenge in the territories in general for capacity to engage, much less to help move this work forward. It's not necessarily the first priority for territories right now, but we're fitting these things in and building the relationships as we go. But as you can see, otherwise we are quite representative across the country, and as I said, the two pan-Canadian organizations, CIHI and Statistics Canada, are part of this network as well. I know this is very busy. These slides can be available to you if you wish, and this one is on our website as well, but this is just to give you a sense that we are supporting multi-regional research that is very much quantitative, data-oriented. This is like every kind of interaction you have with the healthcare system is in here, and we can link these things together at an individual level for people and across time. So there's lots of questions we can answer. And then many of our groups are moving into the social determinants of health data space as well. So education data, most of our groups now have immigration data as part of this, workers' compensation, and then the linkage of large cohorts as well, the Canadian Longitudinal Study on Aging, the CanPath cohorts, these are part of this. And again, researcher-collected data, including some researchers who are doing pan-Canadian data collection, like Corinne Holes, Cedron, the Emergency Department Response Network, those data can be linked as well. It's a matter of consent, of course, but if the consent is there, then we can bring that together. So to support researchers, it's both about the process, it's about providing tools, it's about making sure that we're moving towards building harmonized common data models. We're working on things like statistical analyses that can help us do federated analysis. We know now, and researchers in the room, that you can do really high quality, robust research, even leaving data sets where they are in their original location. We don't have to pool to a central location to do high quality research at this point. So we're building things to do that. But embedded in all of this is a commitment to fundamental sort of starting points for ethics and values-based alignment, and that includes inclusion, diversity, equity, and accessibility. This is an announcement that just came out in the last few days about the implementation of a strategy that we worked deliberatively and consultatively across all of our networks and network partners to build over the last couple of years. And we're aligned with Indigenous data sovereignty. We are not defining Indigenous data sovereignty, of course, as a non-Indigenous-led network, but we are working within our network to make sure that we are able to uphold those principles when they come to us from Indigenous groups, nations, organizations. And we have put funding in place to help develop an Indigenous data sovereignty network for Canada, so that'll be a distinctions-based group that can come together, but also engage with the Global Indigenous Data Alliance. This is just, like, again, a little bit of an eye test, but just to give you a sense of how we organize ourselves, but most importantly, that one of the very, very important features of how we organize ourselves is our Public Advisory Council. I'm using the term public, not patient. This is SPOR, but because when we're talking about health data, it really applies to everybody. Everybody has an interest in this. So we landed on the public thing there, and with that, I'm going to turn it over to Claire to give you more information about that council.
Thank you, Kim. I wish I could have all of my notes in my head. I don't, but I have them written so that I can stay on topic. So thank you, Kim. I'm obviously grateful to be here as a member of the Public Advisory Council for HDNR. And I wanted to say that when I received the invitation to co-present with Kim, I was just both, excited to be here in the room with you, but also very honored because Kim is such a strong leader in the health space. And as I started reflecting about and on what I could share with you today, the excitement quickly made space for anxiety. And that's because anxiety is part of the lived experience that I bring into my identity as well as my role, right? And there is no dissociating the two of them together. And then I quickly thought that I was a woman in my 40s. So I'm a demographic that very much fell through the cracks most of the time, and I'm still parenting a teen through global instability, so I guess I got this, right? So that and the fact that I came to Canada almost out of high school, almost, right? I became a mom and with my husband to a little guy, and I quickly had to navigate a very fragmented healthcare system, completely isolated from my peers, my family, my culture, my people, and in doing so in my second language, because language support was absolutely a joke. So that was me surviving all of this. So really today I probably got this, right? So even with that, I kept wondering if my identity today was patient enough to meet the expectation in the room. And as an immigrant, some of my experiences navigating healthcare systems predate my Canadian experiences by like 20 years. And I can't neatly tell you which one of my health data is a Canadian variable versus a pre-Canadian variable, right? I don't dissociate the two of them because I've lived through them and I've done a lot of work to integrate the two of them. I am also someone who works in the mental health space in the engagement capacity, so I'm not 100% a patient either. I'm a Francophone who lives in a minority community, language minority community, but I'm also able to provide this to you in both French and almost comparably in French and English, right? So I'm not really from a minority group either. So I'm not fitting any of the categories that we typically see in the engagement space in a very neatly fashion. And that got me thinking, right? The ambiguity of my identities is exactly what got me to second guess myself. And if someone with direct, relevant, lived experience, engagement credentials, and a relevant professional background wonders if they're patient enough, if they belong in the room and in the role, right, then what have we been communicating in the engagement space that someone like me is actually going to feel that way, right? And at work, I expose myself to engagement literature and framework and practices, right? So this is not something that is foreign to me. And the categories that we use when we use engagement are very much found across the literature. So that I was preparing for today, and I caught myself reflecting on how the current engagement system frames patient participation in a very specific kind of way. And more often than not, we've come to expect that patient will move the room. I don't have a heartfelt story that is going to move you today, right? I don't have that to share. I'm not here to provide goosebumps either. The room isn't going to fall silent after I share a very deep story of what it's like to navigate the healthcare system here in Canada, right? So that's something that I think matters. And I think that we conflate the impact of engagement with compelling storytelling, and that's part of what I want to bring to the conversation today, because this is very much what we're not doing on the PAC on the network, right? And if patients is something that I want to bring to you, if patients are expected to perform, to lead with their pain, which is very much what we're expecting most of the time, to tell a dramatic story, to justify their presence at the table, then engagement becomes about proving worth, right? And that's fundamentally a very different thing than simply being present with lived experience. And I hope we can sit with that tension for a little bit today. What is it that we ask patients when we invite them to the table? And we really need to take some time to reflect on that. And what does that, and how what we ask serve lived experience, people with lived experience, versus serving something else. And in the engagement space, there's a fairly narrow patient-partner archetype or model where patients are defined by illness and by need and by deficits, which we don't use on the PAC because, like Kim was saying, everyone has health data. So this is not a frame that we follow. The narrow model can make patients question their legitimacy, right? If you don't have a very compelling story, do you actually belong at the table, right? So the archetype of the patient partner privileges acute and dramatic and visible stories, but it sidelines the quiet and the chronic and the administrative and the vicarious experiences, and they're all very relevant to the work that we're doing nonetheless, right? So all that creates a performance expectation where patients are expected to lead with their pain, which frankly can at times be dehumanizing. So we put a lot of intention in how we're working together and how we're showing up together on the PAC while we're working at supporting the work of the Health Data Research Network work plan in doing so, right? So I also wanted to bring a soft light on the fact that the sort of fragmentation of patient identities so they can focus their insight on what's relevant to institutions' questions can be unsafe and even harmful. Not always, but it can be a harmful process. And if you haven't had to go through it, actually, it takes years of self-work to integrate the different parts of yourself that didn't really want to talk to each other. So we have to be very careful that we're not expecting patients to silo their identities so that they fit the questions that institutions would like them to answer. And that's a very difficult position to navigate as a patient, but it's also a very difficult position for institutions to navigate as well. And I recognize that, right? Even if clear and cleaner data may be more convenient, we have to ask ourselves for the convenience of who is it that we're asking for that compartmentalization. And compartmentalization is a process of engagement. It's oftentimes a byproduct of patient engagement. So when I met with Kim to prepare for today, and I asked what part of my knowledge she was interested in, she invited to contribute anything that it is that I can contribute and that I was willing to contribute, right? And that's also why I think we talk about public engagement at HDRN. It's because as a member of the PAC, we volunteer our complete selves. Right? So the PAC is diverse in ages, in genders, in geographies, backgrounds, cultures, ways of thinking, and sense of urgency, right? Very different ways of thinking about diversity, and unusual one as well. And that's the diversity and inclusion that makes engagement safe and productive. Alone, we only represent our own lived experiences and our own health data. But with the rotating PAC membership that we have, which rotates every 3 years, together and over time, we represent Canadian health data realities. And that's sort of how the PAC functions. We keep institutional knowledge by having a rotating membership that trickles over time. And at the same time, we make sure that diversity is represented in the work by having a change in memberships over time. Which brings me to another essential element that I think matters in equitable engagement, public engagement in particular. It's the fact that a group's viability depends on controlling its own institutions and not just accessing others. And that's rooted in minority research, right? It takes institutional completeness to stand on your own 2 feet over time, right? And by and large, patients lack institutional completeness. The patients participate in research and practice, but in the systems that are built and controlled by others, right? At HDRR, the PAC is a modest but non-negotiable structured space. That's why it was on the organizational chart that Kim was showing earlier on. We have terms of reference, annual reports, we have a mandate, we have work plan to some degree. We volunteer projects for the public. We volunteer on projects. We are independent of the organization's work plan, though we are available to contribute in consultation capacity when partners on the network are wanting to talk to us. So we're more than happy to contribute. And we focus on priorities that we believe matter to the public as a PAC. And we are a structure that exists over time and that collaborates with the network for the purpose of making sure that health data, that diverse health data, is represented in the decisions that are going to influence patients across the country and really public members across the country. So what I'm describing really is a question about power. Patients hold knowledge that institutions cannot generate. We often go back to that when we have projects that we're reacting to when they're being presented to the group, which is we can provide information that's not available anywhere else at the institutional level, right? We can talk about navigating system. We can talk about where navigation of the system is actually failing. We can talk about the missing data and the need for institutions to translate that knowledge into meaningful systems change. And that is true epistemic interdependence. We have something as patients, as members of the public, that institutions do not have, and institutions have power that we do not have in order to make systems change actually work, right? So when we look at that interdependence, it would be logical to imagine that we have a fair distribution of power and a fair distribution of resources, which we don't, right? Institutional structures don't reflect that interdependence. So we have power asymmetry, but that is also counting on the symmetrical sharing of knowledge between institutions and systems user. So here we are with facing power asymmetry. That's fine. And since institutions hold the power, then they need to carry the heaviest burden of engagement. And that includes and especially focuses on dealing with the unpredictable participation and inconvenience patients' lives, because patients and members of the public come with very difficult and complex lives, especially when they're navigating healthcare systems, right? because the power asymmetry worsens with intersecting factors, right? And Kim was actually mentioning that earlier on. We're looking at language, income, disability, geography, culture, health status, immigration, caregiving. All of these complicate engagement. These are factors that don't just impact the ability to participate, but also that impact people's interest in participation and their trust and their sense of safety. The most health system reliant patients are typically the least likely to be invited at engagement in an engagement capacity. Those with housing precarity, those with heavy psychiatric conditions or with ongoing substance use difficulties, right? Or the elderly or ESL speakers, just to name a few. These are the group of people that you don't see very much in PAC roles because it's complicated to engage with them. But with what the network is actually doing is really trying to figure out who needs to be at the table, who isn't heard very often, and how do we bring that knowledge, how do we bring those experiences so that we can continue to inform better healthcare system, basically, right? So I'm here making the case to work on the power asymmetry, right? Or at least to align power and burden of engagement. But what do patients bring to the table that no one else does that would justify making more space for patients to be engaged in decision-making, right? In professional circles, we navigate political and operational structures that constrain what it is that we can say and cannot say. So funders bring capitals, we're clear. Researchers bring evidence. Policymakers bring influence. Everyone edits what they have to say based on their institutional stakes, the institutional stakes that they have to navigate. So we self-edit, but patients bring candor. Patients don't have to edit anything, right? The lack of power, the lack of position, of funding, of institutional influence can actually be very freeing. Patients can share their lived experience without the need to edit what they want to say. No one corrects lived experience. You've lived it. It's true. It's true to you, and no one has to tell you whether or not it stands the proof of the system. You just lived it. So it requires no further permission, and there is no authority to supersede it. And that is a very, very unique position to be in, and it's a position of strength. And I think that by merit of candor being an attribute of patients, this is exactly the sort of power that benefits from being brought to decision-making and to the table. Not compelling storytelling, although they are very helpful, given the right time and the right place, but actually being able to speak your mind and say what you need to say about the healthcare system so we can actually work together at changing it and adjusting and improving what actually needs an improvement. So my question to you is, who's at your table? Right? So what is something unique that each person at the table brings that the others around cannot bring? And that includes, is there something that needs to be said but isn't being said? And can you work with your lived experience folks? Can you work with your patients' partners to actually help pass the message for something that needs to be said and that isn't currently being heard? So as a member of the public, as a member of our PAC, that's how I think you can continue to put patients first. It's being very much focused on the strength that patients bring to the conversation and to the table. And with being intentional in leveraging everything that you have at your table, and that includes all the influence, that includes the funding, that includes the first voices that are able to tell you exactly what's going on in the system because they don't have to self-edit anything, right? So in keeping with what I just shared, I hope that has given you, and I have given you some food for thought, a little bit, not as a critique, but as an opportunity to continue looking for more ways to engage patients in intentional and in helpful and useful ways that is actually going to be making the impact that you're hoping your research is actually going to have. Thank you.
Thank you, Claire and Dr. McGrail. And we have time for a couple of questions. And please raise your hand if you have a question. I'm going to bring the mic to you because this session is being recorded.
Thank you. This is a question for Claire. My name is Shanoa. I am a researcher at the Vancouver Coastal Health Research Institute, and I'm a collaborator on the Canadian Emergency Department Research Network, also known as CEDRN. And I'm leading the development of an Indigenous Advisory Committee or Council, so a bit of a different population, but very similar to what I've heard you describe in the PAC. And we have the wonderful problem that we've had overwhelming interest in participating in this council or in this committee. And we're wondering, how do you, or do you keep people who are not currently in the rotation? I know you mentioned every 3 years there's membership changeover. Do you keep others engaged in any capacity when they're not participating actively on the council? And
Right. So the PAC works with current membership, which can be extended to some extent to the degree that someone can actually step into the chair role. And the PAC itself works at supporting projects that are happening across the network so that we can provide our input where and when it is needed. We don't retain a pool of members who are not currently on the PAC so that they can also be brought into projects. But with that being said, there are also ongoing conversations right now on how we can expand the size of the group, so that we can have more voices and more diversity coming to the table. And actually, Kim and I were touching on that yesterday in terms of how we can bring the PAC to projects, but how we can also bring the projects to a wider audience so that we can make sure that we have the diversity. So the short answer is the PAC itself is the membership. The rotation happens sort of incrementally and across time. So it's not that we're losing everyone at the same time and then renewing everyone at the same time. And by merit of that rotation, we always have new voices that are being brought into the conversation. Okay, is anything else that right on?
How are members recruited?
Online campaign. I'm a big fan of LinkedIn, so that's how I found the information. There's a little bit of all of that. There's a little bit of everything. There is the fact that word of mouth, when you, as a patient partner or as a member of the public, you find an organization that is trustworthy, that is actually respecting of the engagement process and the volunteer time that, that PAC members put into it. So there's word of mouth. There is social media campaigns, and there's communications. Because we work at a network level, there very much is about the communication that happens from organizations to organizations. So that's how the recruitment happens. And after that, in terms of process, it's very much a matter of figuring out if we have a good fit with the organization. So I went through an interview or a coffee chat. I think that would be a better description of what it is, which is a very accepting and inclusive space to talk about what I was motivated in achieving by joining the PAC, and a space for me to ask what the PAC was hoping that I would be able to contribute to the work. So that's how it went.
Maybe what I would add to Kathy's question is that just for point of reference, when we, I don't know if this is the last time or the time before, when we went out to do recruiting, I think we were looking for 2 new members and we had well over 100 applications. So the word is for sure getting out. We are still working on members. We have rural, I mean, Clara went through it, but we do have members from rural places. We do not yet have members from the territories. So that's something that we're conscious of, but we also know that that's obviously a bit more complicated for people to think about volunteering for something that's pan-Canadian, because we do get together one time a year in person and then online for the rest of the meetings, trying to work things out. And the other thing we do is make sure that we have simultaneous translation, because we're very focused on including Francophone community, including very specifically looking for people who are first language French speakers. So we do lots of things to try to support all of that.
Any other questions?
Thank you. Danielle Lavallee, thank you for the great presentation. This is probably a question for both of you. Kim, I know you've talked about data stewardship, and I'm curious if having a public advisory committee helps with the stewardship, in particular, creating better access to or perceptions around data not being held too tightly, but really going back to improve research and care.
Yeah, that's a great question. And I would say that we have a mix of stewardship responsibilities in our network members across the country, but most, outside a couple exceptions, really don't have the ability to change stewardship rules or have any particular delegated authority. So we're working much more in a advocacy kind of space there. And we have not yet taken on a project that's very specifically about how we want to be public with this. We've done some work, including with PAC members, on on trust, and how we can actually encourage trustworthy behaviors by institutions to increase public trust. And we have done some other campaigns that are, I think, relevant to the questions you're asking, including lots of conversations with the PAC about supporting private sector and public sector non-academic use of data, which in the case that we've been supporting some of those projects, that it is not about giving data out to non-academic users, but it's about providing analytic services to answer questions that are relevant and clearly have a public interest of one way or another. So that they've been very instrumental in making sure that we're staying within the bounds of what is publicly acceptable there. But I think what you're saying is something that would be a bigger project than that, and maybe you can take that back to the annual planning meeting that's coming up.
Dr. McGrail and Claire, thank you so much.